This is Don Self. I'm the reimbursement consultant in East Texas. I've been doing this for about 35 years. To one or two doctors around the country listen to me on a monthly basis. I've been extremely blessed in that regard. And I am about to teach you a quick little webinar about E&M coding. Okay, I think I've got all three screens working correctly here. Forgive me. It's just really been hectic the last few days, along with Christmas and planning it all out. I did all the calculations for next year, and then a few nights ago, Congress submitted in the bill to the president, which totally changed everything because he signed it last night. So I've been having to redo my webinar. Okay, first off, let me clarify that I am not an attorney. I don't play an attorney on TV. I'm not an NFL player, a movie star, any of those experts out there, or basically blowhards is what I look at them as. I don't know why you people listen to movie stars and entertainers anyway, because they're never mind. Anyway, 2021, what are we looking at? 2021 brings great hope and excitement. There's going to be a whole lot easier documentation on evaluation and management. There's going to be permanent telehealth coverage, as it says there. And I'm not one of those that's going to read down the screen. You can read as easily, or probably better than I can. There is going to be new prolonged service coding, and we were still hoping for NP parity, but it looks like now that Trump is going to be leaving office and Biden's going to be coming in. I doubt if we're going to get that NP, nurse practitioner, and PA parity. Trump was asking for that twice in the last 14 months. Still haven't gotten it yet, but that's one of the things that was on his agenda. And as far as this new year, we should be seeing somewhere between a 7 to a 19% increase for primary care providers. Other providers are probably looking about a 3 to 4% increase. You say, well, why should primary care providers get so much more? Well, if they're working smart, they should be getting about, probably the majority of them should be getting about a 40% increase. But vast majority of primary care providers are not doing what they should, as I'll show you later in this. I want to say a special thank you to Barbara Cabuzzi. Barbara has done an amazing job on many of these slides here that she shared with me and gave me permission to use. I've known Barbara about 20 something years, I guess. She's younger than me and got started in the 90s, I think. Like I said, I've been doing this since 85. But Barbara's been an amazing asset to tens of thousands of people out there. I just want to say thank you. Now, going back a little bit of timeline right here, back in 91, 92, many of us remember whenever we adopted the RBRVS systems and we changed up how we'd been calculating the Medicare allowed amounts. Then in 1995, CMS came out, and well, at that time they were not CMS, they were HCFA. HCFA came out and said, okay, here's a new set of guidelines. We want you to follow it. Throw away SOAP, because subjective, objective assessment and plan do not meet these guidelines by themselves. And then in 97, because so many providers have been screaming and whining and crying that they didn't like the 95s, they came out with a new set of 97. And they said, okay, throw away the 95s. Well, again, some of the providers out there, doctors, groups, I believe it was ACOFP and the AOA and some others, threw a hissy fit and said, no, we like the 95s better, or the surgeons like the 95 better. So they said, okay, fine, you can use either 95 or 97. And they were planning on making another change in 2000, but then the entire HIPAA thing got in the way of that. So they finally made these new changes effective for 2021. Now, keep in mind, it only affects some codes. In fact, not very many codes, about 9 codes. But we're going to go over those changes on those 9 codes today. So the 95, 97, I haven't started teaching the 2021 because so many providers today are still confused about 95 and 97, and not just providers. It's not just the physicians and nurse practitioners. It is coders, it's billers, and it is even certified coders. It is sad how many people are so confused about it. They think that the 95 and 97 is so complicated. I mean, I think that was the one thing that I scored a 100 on my CPC test was E&M, because it's not nearly as complicated as people like to make it believe. Now, as far as the new rules go, which one are we going to be using? Well, 99201 we're going to say goodbye to. And we got 99202 through 99205 and then 99211 through 15 are all going to be used in the new guidelines. Now, if you're talking about a hospital visit, you're talking about nursing home, assisted living facility, hospital discharges, etc., those kind of things, those are all still going to be using the 95 and 97 guidelines. It's only going to be the office outpatient visit codes that are going to be using the new ones. Say, okay, well, if I wanted some of this information on these others, because you say it's so easy, yeah, you can go to donself.com /EM, and you can watch the three little free 10-minute webinars I have on the 95, 97 guidelines. And you got to bring your own popcorn because I don't provide that. But these things are really super easy to understand, the 95, 97. So if you've been having trouble passing the CPC test or the test through one of the other associations out there, watch those three little free 10-minute webinars. I'm hoping to have some more little webinars like that on this subject in the new year. I have just been totally swamped between our RPM business and all the last minute changes Congress has done. And as usual, like I said, they normally have their head up their butts trying to do everything until the last minute to make the president look bad or make whatever their motivation. I don't know. I'm beyond dealing with those morons. Anyway, the 2021 changes. Again, most of the changes that we're talking about right here affect the office outpatient visit codes. And we're talking about the changes being MDM and time, because it's all going to boil down to when you're looking at the office visit codes in 2021, did they document MDM, medical decision making? Did they document time? Which one gives you the higher code? That's the one you're going to use. Plain and simple, end of story. It's really that easy. And yet so many people are making this thing so complicated. And we also have a new reduced prolonged services code, and I'm going to go into detail on that in a bit. I'm going to be talking about your increased relative value units because CMS increased the RVUs. They were planning on making a big cut on the conversion factor, but this last bill that was submitted that the president signed last night changes that. Again, I'll go into detail on that more. The whole idea behind this falls into the thing that Trump's been pushing since 2017, and that was less paperwork, more patient care, or patient care centric. And I don't care if you like Trump or not. If you don't, that's your own ignorance. But one of the things about him is he's done an amazing job on helping reduce the paperwork and the regulations in this country that we have that's been basically putting handcuffs on businesses. One of the things we get to do now is we're going to be able to count times. Starting next week, January 1st, we're going to be able to count time, pre and post time. The way we have been able to since June with telehealth services. I know a lot of people still totally miss that, but that's been a change that we've been able to do with telemedicine for, well, about 6 months now, a little bit longer, counting pre and post time. I'll go into greater detail on that as well. Overall, this is designed to save providers about 180 hours a year that they've been spending on notes and documentation they can now send on patient care and hopefully have fewer burnout, less burnout. I mean, hallelujah, it's time to party down because so many doctors and nurse practitioners and PAs, they go through burnout too quickly. Let's say goodbye, by the way, to our good old friend 99201. We've had 99201 since about 1983, if I remember correctly. And now we're going to be going with time or medical decision making on the 99202 through 215, whichever is greater. And don't forget, medical necessity is still key. You're going to still be asked, okay, why did you spend an hour with that patient? And the only complaint was they had a splinter in their finger, or they had an abscess on their butt, or whatever it may have been. The office visit codes are going to be substantially redefined, as it says. Okay, they've changed the time, and we're going to go into detail on that as well here for you. When we're talking history and exam, you still have to document it. Otherwise, you're going to have your malpractice attorney going we all in their pants. So you've got to still document the history and exam. And Medicare even says it needs to be an appropriate one. But you're not going to be counting that right there towards the level of code. You're going to use that to show the medical necessity. And that's kind of simple. I mean, no longer we having to count all the bullets in the review of systems, bullets in the history of present illness, bullets in the past family social history exam. I mean, and or the exam. I mean, a lot of things are changing right here to make it simpler for y'all. So please don't go trying to make it more complicated to your providers. They already have enough on their minds with the COVID and all the other garbage out there. Try to keep it simple for them if you can. One of the components is out here is going to be, again, one of the two components is medical decision making. And just like we've had now for the last, 23 or 24 years, it's going to be two out of the three elements in medical decision making. You say, well, I never did quite understand the MDM before. If you ever want to, you can go and watch that little 10-minute webinar on the website about MDM and see how easy it is, because you're still going to be using that for the non-office side. Now, time, the other component, is going to be either MDM or time, whichever is higher. Time will never bring you down. You say, well, is it possible to do a high level, moderate, or complex medical decision making and get a higher level code, even though you may have only spent 10 minutes or 12 minutes or 17 minutes or whatever? Definitely. Time is not going to drive it. You say, well, in the past, hasn't time driven where half of the visit had to be spent counseling and the coordination of care? Yeah, and that's still the way it's going to be for non-office type services. Okay, hospital, nursing home, assisted living facilities, home visits, those things. Yeah, only way you're going to be able to really count time in that is if more than half the visit was spent counseling and or coordination of care, and you still got to document time. When we're talking about the office visit services, though, time's easy. How much time did the doc spend pre? How much time did they spend during? How much time did they spend post? What were they doing? Well, I spent 5 minutes right there reviewing the chart before I got the patient on to if the patient came in. Well, the same way you do today. Before I jumped on to an audio video call with a patient, I spent 5 minutes reviewing the chart. And then during the time, I spent 15 minutes on an audio video call using Skype or FaceTime or whatever with the patient. Well, starting next week in January 1st, you can say I spent 15 minutes face to face with a patient and their family member. And again, whatever you were doing, you need to show that. And then the post time, I spent 6 minutes afterwards documenting it and writing a prescription and ordering some additional tests and conferring with somebody else, et cetera. Well, that's all I'm asking for. You say, well, do you have to document start stop time? No, you still got to document start stop time for prolonged services. You got to document start stop time if you're in anesthesia. But most of my clients, in fact, none of my clients were in anesthesia. 99% of my clients are primary care because those are the ones that I can always make an extra 100 or 200,000 a year. So anyway, the time is there. You just got to count the time. And yes, I did say we get to count all that time. And as I said too, you can do that now for telehealth. But starting January 1st, it's going to be permanent. Okay. And this is great news right here. That gets us all excited right there. Now, what about the times? Which time we're going to use? You say, well, didn't they come out in April 6th Federal Register and use this new times here? And then they finally said on May 14th, oh, but don't worry about it. Just go ahead and use the time in the CPT book. Yeah, that's what they did this year, 2020. Been a strange, crazy year. But now we're going to be using the times that's in the 2021 CPT code book. And this is going to be the first time now that Medicare and CPT is, equal. You say, well, haven't they been in the past? No, in the past, Medicare had one set of rules on time, where it had to be minimum or threshold time, and CPT had nearest time. Now we're going to be using the times that's in the CPT book right here. Again, if you're still talking about nursing home, hospital, or those kind of things, still going to have to code those the way you did in 2020, 2019, 2018, all the way back to 1997, 1995. But if we're talking for the new ones, we're talking about the new rules. Now notice something right here on all these codes, and I need to make a change on this right here because, well, I'll tell you in a moment. But notice right here, the 2020 times right here and the 2021 times. And you can see 20 like a 99203 is 30 minutes. Well, you say, wait a minute, that's 30 minutes also, 2021. Yeah, but there's a reason that you're getting to know what the highest level code is. There's 44 minutes on it, or the highest amount of time. And you'll notice the ORVUs jumped up from 1.42 to 1.6. And those doctors and nurse practitioners and PAs and providers being paid off of ORVUs, I'm sure they're going to love this right here. Notice 99213 is 15 minutes this year. In 2021, it jumps up to 20 to 29 minutes. So, well, that doesn't sound fair. Well, notice ORVUs went up, but also keep in mind in 2021, you get to count the pre time, the during time, and the post time. Oh, yeah. Well, that's going to add up. Overall, this is not going to be a reduction, not for any doctor in the country, unless they're just a complete moron when it comes to documentation. Okay, that's cool. And that G2212, what's that with 15 minutes and the G2211? G2212 is a prolonged service code I'm going to go about, and just ignore G2211 because G2211 just got tossed out the window until 2024. We're not going to be using it. Medicare, CMS just dropped that thing until 2024. And so we're not going to mess with it. Now, as far as the new guidelines for 2021, if we're talking about outpatient, it's pretty easy. You'll notice right here 99202 is straightforward level, 99212 is straightforward. Under the problems, minimal and minimal. Under data analysis, minimal and minimal. In other words, the same level for new patient as you have for established patient. They're going to try to keep this thing simplified, which I'm glad. But where in the past you had to count the number of medications a patient was on and the number of diagnoses, and you didn't really worry about the severity of the diagnoses, that's all kind of changing. So there is a little bit of change right here. And again, I thank Barbara Cabuzzi for doing a wonderful job on these slides right here on this webinar or seminar that she shared with us. Well, when we're talking medical decision making, now we're going to be looking at not just the number of the problems, and in the past we called them diagnoses, but now we're going to be calling them problems addressed at the encounter that's clinically relevant to what it is you're seeing the patient for. But we're also going to be looking at the complexity. Straightforward is more like a self-limited problem, such as runs a prescribed course no matter what you do, a code. That's going to happen. I mean, I'm going to give you this magic drug right here, and your code's only going to last about 4 or 5 days. Oh, thank you, doctor. Wait a minute, the code only lasts about 4 or 5 days anyway. So, you know, it's a problem that has a prescribed course. It runs its own. Low, it'd be like a controlled diabetic follow-up. It's stable, uncomplicated. Single problem right here. Sometimes patients are going to come in though with multiple problems like a controlled diabetic and hypertensive, or an uncontrolled diabetic. That would be falling into this category of moderate right here. Or uncontrolled hypertensive. That would fall into this category. Now, high is going to fall into under the MDM, under the nature or the number and complexity, would be an acute MI, pulmonary embolus, severe respiratory distress, severe rheumatoid arthritis. You notice that these right here are all severe. It's like I just went and saw my doctor because I was having some more chest pain and a lot of yawning and stuff like that. That wasn't severe because I just take my nitro and it goes away right here. These are patients that we're trying to decide whether or not this patient needs to be hospitalized and put in ICU. And we're talking pretty severe people right here. So, I mean, severe patients right there. So that's, we're talking about the problem. Now, what is a problem? A problem can be a disease condition. It can be the symptom, the complaint from the patient, et cetera, that's being addressed during the visit. You don't even have to know what the diagnosis is. A patient comes in and says, I'm sleepy all the time. You don't have to determine whether or not that is cardiovascular related, or whether it's neurological related, whether or not the patient's parasympathetics are too high, sympathetics are too low, whatever it is. You don't have to have a diagnosis because the problem can include the complaint and symptoms as well. Oh, okay, that makes sense. By the way, people ask often, what is the difference between a major or minor? Minor surgery, minor is a procedure of surgery that happens to somebody else. A major one's when it happens to me. Okay, so that's at least that's my own definition there for you. Now, when we're talking on problems being straightforward, that's more like a self-limited or a minor type problem. And you go all the way back to the 1928 dictionary, typhoid fever was an example of a self-limited disease. It's going to run a certain course. No matter what drugs you give the patient, it's going to run that course. A sprain, a common cold, upper respiratory infection, those are all simple, straightforward problems. And there's no exhaustive list out there that I've been able to find, and I've looked for one. Just remember, straightforward is self-limited. That same definition right here. Sometimes you look at a problem being low problem. Okay, that would be like a chronic stable illness. I have hypertension. I had it now for about at least 3.5 years since I had the heart attack. So, but I'm keeping my blood pressure pretty controlled right here most of the time, and I'm pretty close to my specific goals. Or maybe if not, I'm real close to it. Okay, and or it could be an acute problem right here where you expect full recovery without any kind of deterioration or additional kind of ongoing treatment after that. Again, it's not resolving right here, and that's why. And I will have hypertension, I guess, the rest of my life. And my wife has controlled diabetes, and she's going to have that the rest of her life right here. A moderate problem would be one that's basically causing more problems. It's worsening. It's poorly controlled. Say if my blood pressure was running 150 over 95, I think that's above the range that they're looking for. If my wife was running an A1C of say 9 instead of, I think she's about 6.8 on her A1C, that would be an exacerbation right here. Or you could have something that's even not diagnosed and you're still trying to figure it out. And someone's used the term, I forgot what that term is when they hadn't figured out what the problem is. It'll come to me later. I hate it when I go blank on a name. But say again, those are moderate problems right there for chronics. Now, acute moderate problems could be something that causes systemic symptoms or has a high risk for morbidity or a high risk of mortality or something like that right there. Or some kind of a complicated type of an injury where it's not just a sprain or just a simple break right here. And this right here is going to heal itself once you get it stabilized. Those right there would be a moderate problem under the acute side. Now, if we're talking about high problems right there, these right here is, let's say I have diabetes, it's uncontrolled, and I have hypertension that's uncontrolled, and that they're posing a threat to my body, my treatment, etc. Then those right there is what we're talking about when we're talking about the high level problems. Now, keep in mind, if we're talking about other E&M visits, you're still going to use the same MDM, medical decision making guidelines, that I have in that little 10-minute webinar on my website. If we're talking new for, it should say 2021, we're missing a zero there. But if for 2021, you're using the guidelines that I'm telling you right now. Now, occasionally you'll hear me talk about tests, or you'll hear people when talking about medical decision making talking about tests, as I will in just a moment. Those are like lab services or diagnostic imaging. Like I think Wednesday I'm having a stress test and I'm having an echocardiogram and stuff. That would be, physiological test right there. And chances are if they're going to run some blood tests on me right here. If they're doing just one test and then they're doing a different one, those will be separate tests. But if we're talking about like a panel, basic metabolic panel, BMP or whatever I think they'll call it, that's counted as one test. Chest x-ray of multiple views, that's counted as a single test right here in the guidelines I'm about to show you. And this is a guide right here that AMA put out. And normally I don't like the AMA stuff, especially when it's been about the telehealth stuff, because I feel like they put out a lot of garbage in my opinion. But this guide right here I really do like. And you'll notice 99202 has the same rules. 99203 and 213 has the same rules. So new and established both have the same rules. Now, 99211, that really hasn't changed. That's still going to be the nurse doing the blood pressure check the way they always have in the past because the patient has high blood pressure or something like that. And by the way, you can still do a 99211 today, telehealth, and after January 1st, because telehealth rules don't change January 1st, for the nurse doing an audio video with the patient, or the pharmacist in your office. It's an employee doing an audio video with a patient, going over all their drugs. You could do that before telehealth. You can do it after telehealth. CMS was very clear about that on a May 16th teleconference call that they had on their Tuesday, Thursday calls. And I even have a link to that one on my website under the COVID page. But take a look at 99202, straightforward. Minimum, self-limited, a minor problem right there. Just one of those right there. Minimal type of medical decision making right here based on the complexity and just minimal risk of morbidity. something minor right here. The patients were monitoring a code. Patient came in. That would be like a 99202. 99203 or 99213, again, that's a low level of medical decision making, would be two or more self limited or minor problems, or one stable chronic illness. I go in and see the doctor and I have my hypertension is under control right here. And maybe the doctor's just checking my meds right here to find out if she needs to change my metoprolol or that stuff that she gives me for angina. That would be simple. Or one acute, uncomplicated injury. I go in and say, hey, I hit my elbow right here, and can you check it out right here? And she checks it out and says, yeah, it's a bruise right here. It's uncomplicated right here. That's acute. Okay. Then you look at the data that the doctor's looking at or medical providers looking at right here. Any combination of two of a view of prior external notes of reviews of each unique test. And by the way, when we're talking testing right here, you can't count the bullet right here in this area if you're the one that's ordering and billing for the test. Like, let's say you order a chest x-ray being done by a radiologist down the street. Well, you're not billing out for the x-ray or the interp, so you get to count it right here. Well, let's say you say, I want you to have an EKG and I'm going to bill you for the EKG. Then you don't get to count that point here and get paid for the EKG both, because that would be kind of double dipping. And CMS has figured out a lot of people have been double dipping in the past. So we got to watch out for that. So you get to count it right here if you're ordering it, but you're not the one billing for it. Or if you're reviewing the results right here of this right here, and you wasn't the one that billed for doing the test right here. So then we get to count it right here. Or if you're having to do an assessment with a independent historian, such as you're calling a caregiver or you're asking the caregiver to come into the room and asking them questions, et cetera, that gets one count there as well. And under the area of risk of complications and morbidity and mortality, it's just a low risk right here, because they're saying, okay, this test I'm doing is not going to put you at any kind of a high risk right here or moderate level of risk. Now you look at a 99204 or 214, moderate level of MDM, moderate level, and I wish I had different names right here because it can confuse things, but it's just moderate all the way across. The low was one before it, or limited. And then high extensive is the highest level. But under moderate right here, one or more chronic illnesses, but there is some kind of exacerbation or progression of side effects in this patient. Or we got two stable chronic illnesses, like I've got diabetes or hypertension in both. Well, let's say I've got hypertension and well, I don't know if I have any other chronic disease. Well, my wife has diabetes and hypertension both. So that would put her into a moderate area here as long as they're both stable. Okay. Well, we have a new diagnosis with a new problem, an uncertain prognosis on it right here. That would throw us into a moderate area right here. Or an acute complicated injury. And none of those right there come to mind. Well, okay, yeah. I'm supposed to have had a toe joint replacement. Well, I did have one last December, but it didn't take. So now, a sleeve. Now they're going to go in and replace the whole joint, but my cardiologist won't let them do it. So that would be a complicated injury, for instance. But now you're looking in under the complexity of data being reviewed and analyzed, and any combination of three from the following: review of prior external notes, as I talked about before, review the results of each unique test. Again, these are not tests that you're billing for, and ordering of each unique test. Or you're doing an assessment, again, requiring an independent historian, where you're having to ask questions of another historian, caregiver, etc. Or you go into category two, independent interpretation of test. Independent interpretation of a test performed by another physician, not separately reported. In other words, you're not the one billing out for that one either. And you're going over a discussion of management of these kind of results right here with another provider, another healthcare giver. Those right there will give you categories that you can pick from. So it's really not complicated. I know there's a lot of data that are looked at, but after you start doing this a few times, you think, wow, check off easy. So you coders are going to find this thing right here is really easy. So is the billers. It can be intimidating at the beginning when you first look at it because it's something new. Go over and look at the moderate risk. If you're doing prescription drug management, like my wife just saw her doctor not long ago for diabetes hypertension follow-up, and she was changing the meds. That would throw it into that area. as far as the risk of complications. And then the high, again, we're talking about some side effects of the treatments, or we have chronic illnesses with severe exacerbation progression. Well, you find that a lot of times with renal failure, congestive heart failures, etc. I know I watched my father-in-law when he's going to these visits right here and just kind of see how well he's doing, but sometimes he's not doing so well. And he really definitely going to be in the high area. Acute or chronic illness or injury that poses a threat to life or bodily function. They have to be willing to kill them, but if they're not going to have any more body function out of that right there, then it's going to apply to it right here, whether or not we're talking about some kind of an organ or we're talking about a limb. Then is extensive type of data being reviewed, or the complexity of data, as you can see, the same kind of there, but now we have to have a combination of three of these. Like you also had there, three under moderate. But then you look over at high risk, such as a decision requiring hospitalization, regarding hospitalization. They don't have to be hospitalized, but you're making a decision as to whether or not you want to hospitalize them out here, or you're making a decision and going over the end of life decisions with the patient as far as resuscitation and all. So, I'll give you an example right here. Let's break this right here down a little bit. Let's say that I am looking at a report. My wife went in and did a follow up with a doctor, and she's got diabetes and hypertension. Okay, two or more stable illnesses, and they're both stable. But the amount of data that the provider is reviewing is, well, limited. It's not very high. It could even be minimal. Okay, but at the same time, the level over here, because the doctor was doing prescription management, that means we got two smiley faces in the moderate level. So the medical decision making for this particular patient right here would be moderate. So remember that they only have to have two out of three here, the two highest. Oh, okay, that makes sense. That's cool. Now let's take another one right here. And let's say we have a patient that is in the high area over here. Maybe my wife has diabetes, hypertension, and her hypertension is through the roof. And on top of that, right there, the doctor's worried about her kidneys now because of her hypertension. And so that would throw her into a high area there on the number and complexity. Now, maybe the doctor only had right here a moderate level of analysis of data being reviewed. But let's say that she was decided having to make a decision whether she wanted to hospitalize my wife. In that case right here, we're going to have a high level of medical decision making. Okay, that's pretty easy. And it doesn't take much to hit these points right here. That was relative, I mean, to the visit that's applicable to today's visit and the chief complaint. Once again, the highest wins, medical decision making or time. So maybe you only spent 15 minutes on this right here, but you had a moderate level of medical decision making. So you got a 99214, even though the time might have been a 99212 or 213. So the medical decision making is not going to be dragged down by the level of time. So now we also have coming up this year, January 1st, 2021, a new prolonged service code right here, G2212. You say, okay, well, is that different? Does that basically make a difference? Yeah. In the past, you've been able to use a prolonged service code, 99354, the 99358, etc., with each of the different levels of E&M. Now you can only use this new one that's 15 minutes or more, and it's a threshold time. You don't get it half of it if you spend 8 minutes more. It's got to be 15 on this one right here, and it's got a little bit over half of a work one work half of one work OVU on this right here. Is a G2212, and it can only be used with a 99205 or 215. That's it, the highest level of office visit code. Was this the only code that we can stick it with it? Yeah, these are the only two codes. You can't use this prolonged service code with any of the other, like a level 3 hospital visit or a level 5 home visit or anything like that. This only goes with the office visit codes 99205 and 99215, the highest level of those. The new code G2211, as I said, canceled until 2024 thanks to that congressional pork bill. I call it a pork bill because there was billions and billions of dollars being spent on pork on this bill, because the only way they can get every one of the Democrats and every one of the Republicans that they had to sign it was if they promised them something. Yes, your favorite little package gets thrown in there, and it doesn't matter if our great grandchildren will ever pay off that debt, and they have taxes at 60, 70%. You know, I'll be dead by then, hopefully. So I'm not worried about it. It just irritates me. Okay. Now, out of this entire thing, I got to tell you, this is, while I dislike all the pork, in fact, I detest all that pork that's in there. Okay. And I'm not going to go into great detail on that. I do like what they're doing for the physicians. This adds about $6 billion to what they're paying the physicians, nurse practitioners, PAs, hospitals, clinics, etc. So I do like that part right there. But one of the things about telehealth, because we had telehealth codes added, and we added again April 30th, and we had them updated again December 21st. So if you go to donself.com/COVID, you can download the December 21st update that's on there. And that gives you a list of all of them. In fact, this month, if you subscribe to my monthly newsletter, I included every one of those in my normal 8-page newsletter. In December, it's 15 pages. I know. There's a lot to cover though. So and every month I try to stay on top of everything for you with the newsletter. So, but, but telehealth has given the doctors in primary care a huge choice. I know there's unfortunately many of them still do not realize that Medicare patients are the most profitable of any patients that a primary care physician could see. Medicare Part B patients are, maybe not all Medicare Part C plans, but Part B patients definitely are. And you say, really? I've heard just the opposite. Well, there's a lot of lies out there. I guarantee you one thing, I'm going to show you how primary care physicians make a lot more money off of Medicare Part B patients. In fact, they should be making about $1,785 a year for every Medicare Part B patient they see if they're doing what Medicare wants them to do and they're billing for it properly. Unfortunately, most nurse practitioners oh no, in fact, nurse practitioners should be making around 1,500 a year because they're still getting that 85%. But most are averaging less than $150 per year. Most physicians are averaging less than 200 per year. Seriously? Well, where do I get the 1785 at? Well, if you take a look at it and see office visits, diabetics should be seen 4 times a year. Well, where do you come up with that? The very first PQRS that came out in 2012, very first one said Medicare expects you to do an A1C 4 times a year on each Medicare patient if they are controlled. It also said you should be doing an A1C on every visit if they're not controlled. You say, wait a minute, isn't that a 3-month average? Yeah. But keep in mind, if you see them once a month, then this month is going to count the last 2 months. Okay, I see what you say. It's better maintenance on the patient. Yeah. Unfortunately, some doctors still don't do that. In fact, I would say the average primary care doctor does 1.2 A1Cs a year. How do you know that? I have everybody's billing record on this computer I'm looking at right now. And that's why I know what every doctor in the country has been billing. Everybody's, yeah, it's all public information as long as you know where to go to get it. And that's eSimplify. eSimplify has really helped me a lot, by the way. EKGs once a year. I mean, I know I just saw my cardiologist the other day. Time to do one. Spirometries, if they have any kind of congestive heart failure, COPD, asthma, breathing problems, a little simple spirometer. Annual wellness visits, you say that's more than we're getting. That averages between a GO438 and GO439. The national average is 151 when you average the two. Advanced care planning, about $90 on that. That's where you're going over the end of life decisions with the patient. Well, what's going to happen if they we find them not breathing? Do we want to hook up the battery cables to the Toyota and try to jumpstart them? If we get them jump started, we put them on a machine. If we can't get them jump started, does the patient want to have their body cremated and the ashes put in a Maxwell House coffee can in the backyard, or sent to the veteran cemetery because the veterans are plant free? That's where I'm going to be going. If either them or their spouse was a veteran. Depression screening, alcohol misuse screening, chronic care management. It's amazing right now. I'd say less than 11% of providers in the country are doing chronic care management. I've got most of my clients following my advice on how to do that. And how did I go forward over here? I didn't mean to do that. Cognitive testing, there's the right ways and wrong ways to do that. Cognitive assessment planning. I think right now less than 2% of the providers in the country are doing that. Look at that, 276 bucks. Medicare keeps throwing money at it. If Medicare throws money at something, that's their way of saying, hey, docs, get off your butts and start doing it. Because that's a lot of money. I mean, you can look at basically making 150, 180,000 a year by doing two of those a day. Cognitive assessment planning that Medicare wants you to do. So come on, and you sit there and say, "Well, now I'm starting to see why doctors aren't making any money. They're not following your advice." Some of them do. Remote physiologic monitoring, that's huge. $1,400 a year on average. Average. And transitional care management, you say, well, that totals up to what? That's about $3,000 a year. And not everybody needs all of that. So if they use 75% of this right here, that's still $2,200 a year. And if Medicare only paid 80%, even though we know that Medicare pays 100% on some of these things right here, you're still talking about $1,785 a year. And if you're a nurse practitioner or a PA, that's still $1,517 a year. And you say, well, most of them are averaging a lot less than that. Yeah, I just did. In fact, I'm going to show you some slides here in just a moment. And this is basically showing you how to take advantage of all the telehealth rules right here. There's a lot of telehealth out there that's available. I mean, things that you could be doing. You could be making almost that much money, 1,500 a year, without having to see the patients in the office, just by following the appropriate telehealth guidelines that's out there. And telehealth saves money right there. I mean, it saves money for the Medicare system and saves lives. You said something about the monitoring. Yeah, yeah, as Gregory House said on his TV show, Patients Lie. I watched my own dad lying as he was filling out his blood pressure report as I was driving him to the cardiologist about 10 years ago when he was still alive. And I said, what are you doing? He said, I'm filling out my blood pressure report because my cardiologist likes to see it. Well, you know those numbers aren't real. You're just making them up right now. Yeah, but it keeps him off my back. And I doubt if my dad was the only one lying to the doctor. So let's say you send the patient home with a blood pressure meter. And every time the patient checks their blood pressure, it automatically transmits and uploads to the receiving station right there. Um, there's the doctor's staff checks the numbers every day or every other day, and they're spending minimum 20 minutes a month on the management by the staff. Well, that turns out to be quite a bit of money because you're talking about the setup fee, the providing the monitor to the patient. You say, really, does Medicare pay you 65 bucks? Yeah, that's the national average. You go to Alaska and it's probably about 90 bucks. Go to Mississippi and it's probably about $52. So it varies upon where you're at in the country because the costs are different right there. And so is the locality indicators. And then you've got for the staff spending 20 calendar minutes, you say, wow, that's $52 for 20 minutes. That's more than we make on chronic care management. Yeah, Medicare is concentrating on this right here, right now. And let's say if we're just talking about a nurse practitioner, we're talking about an allowed of about 100 bucks. If they're spending $41 a month on it right here on the system, and you say, where do you come up with that? I know a company that does nothing but this, Telecare USA. You say, well, how do you know them? Well, I'm the president of that company because we opened it in February of last year. Well, January, we were opening it last year in January 2019. And it's just gone through the roof right here. We've gone from about a $300,000 a year company and to about 700,000. And the way this quarter is looking, and next quarter we're probably going to be closer to an 8 million a year company because everybody is signing up for this kind of stuff. That's still $700 a year. You say, well, and the providers aren't making that kind of money now. No, the average provider makes less than $300 a year. Many of them are making less than 200 a year per patient. And what other kind of telemonitoring? Well, we've got blood pressures, glucose, oxygen, oximeters, and that's mainly for the COVID. It was the first year for our COPD patients. And then these right here look like they're Bluetooth. They are. But if the patient didn't have Bluetooth in their house or like smartphones and stuff, then we've got a blood pressure glucose monitor that works off of SIM card technology. But that's a totally different subject right there. About 130 years ago, a preacher was traveling through East Texas and stopped and set up a tent out there and said, Saturday night revival, 7 p.m. Well, Saturday night rolled around and only one cowboy rode up and got off his horse and walked in that tent. And the preacher looked at that cowboy and said, well, cowboy, I'm not sure what to do. I normally have a tent full of folks. Cowboy says, I ain't book learned, Pastor, but it seemed like if I'd gone out to feed my cattle and one cow showed up, I'd feed that cow. So the preacher got up there and preached a good 35, 45-minute hellfire damnation sermon. I mean, he covered all of the different gospels. And then at the end, he stops and looked at that cowboy and said, well, what do you think? And the cowboy said, I told you I ain't smart there, Pastor Man, but it seemed to me like if I'd gone out to feed my cow and one cow showed up, I'd feed the cow, but I wouldn't dump the whole load on the one. I know I tried to make this right here manly about E&M, but I got a feeling I dumped a whole lot more on you. I've been helping practices since 1985, and there's a whole lot of free stuff all over my website. And since, what was it, March 28th of 2020, I've taught so far 36 webinars this year to different AAPC and nurse practitioner and physician groups on these kind of subjects and ERISA and E&M coding and telehealth and all that kind of stuff. So if you need me to speak to your group, just let us know. If you ever want me to spend an hour with your doctor and your office manager and your biller, at the end of the hour, I'll ask them, did this hour just help you make 20 grand a year? And if you say, yep, then you can pay me my $500 fee for that consulting. If you say, nope, you didn't, then you don't owe me a penny. That's how it works. It's really that simple. Visit donself.com. And if you like this right here, even though it was free and you don't get CEUs, do me a favor. Think about going to Google and giving me a 5-star review on that right there, because some people are Google hogs and they just got to go check Google before they hire anybody. So I want to make sure I keep them happy. I want to say thank you for letting me be part of this, part of your life right now. And let's go ahead and I will stop this thing right here and end this webinar. Thank you.